Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the gluteal region. In this lecture, we're going to be discussing the bones and joints of the pelvis, features of the femur, the hip joint, and then the muscles, innervation, and blood supply of the gluteal region in general. Now, I'll be back later for a clinical correlation and the end-of-session quiz, but for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
If you've watched the Solid Anatomy lecture on the pelvic wall, you are probably already familiar with some of the material we'll be covering in this lecture. The muscles of the gluteal region, for example, originate on the bones of the pelvis, and the blood vessels and nerves of the gluteal region originate inside the pelvis. The bones of the pelvis, namely the sacrum and the paired os coxae, or hip bones, are arranged to form a girdle. Each hip bone is formed by three bones that fuse during development: the ilium, the ischium, and the pubis. The ilium has a thick body with a broad, flat wing, or ala, extending from it superiorly. The arcuate line on the medial side of the ilium, which contributes to the pelvic brim, is the boundary between the body and the ala. The curved superior edge of the ala is the iliac crest, which ends anteriorly at the anterior superior iliac spine and posteriorly at the posterior superior iliac spine. Projecting from the ala inferior to the crest are the anterior and posterior inferior iliac spines. Inferior to the posterior inferior iliac spine is the greater sciatic notch. The concavity on the medial side of the ala is the iliac fossa, which is filled by a muscle, the iliacus, that will be described further in the Solid Anatomy lecture on the thigh. Posterior to the iliac fossa is the auricular surface, named for its ear-like shape, which is the articular surface for the sacroiliac joint. The ischium has a body and an arm, or ramus. The ischial spine projects posteriorly from the superior part of the body, while the thick, rough inferior part of the body forms the ischial tuberosity. The ischial tuberosities bear the weight of our bodies when we are in the seated position. Between the ischial spine and the ischial tuberosity is the lesser sciatic notch. The body and ramus of the ischium surround a portion of the obturator foramen. The remainder is surrounded by the pubis. The pubis consists of a body and two rami. The inferior pubic ramus joins the ramus of the ischium to form the ischiopubic ramus. The left and right ischiopubic rami form the pubic arch, and the inferior edge of the pubic arch is the subpubic angle. The ridge on the distal part of the superior ramus of the pubis is called the pecten pubis. In the Solid Anatomy lecture on the thigh, you'll learn that this bony landmark serves as the origin of the pectineus muscle. Extending superiorly from the proximal part of the superior ramus is the pubic tubercle. Recall from the Solid Anatomy lecture on the abdominal wall that the inguinal ligament runs between the anterior superior iliac spine and the pubic tubercle. The medial side of the body of the pubis is the symphysial surface, the articular surface for the pubic symphysis, a joint between the right and left hip bones. The socket for the hip joint, which is located on the lateral sides of the os coxae, receives contributions from the ilium, the ischium, and the pubis. Since this socket bears such a striking, undeniable resemblance to everyone's favorite culinary object, the vinegar bowl, its name is the Latin word for vinegar bowl. Ready? Acetabulum. The acetabulum is lined with articular cartilage and forms the hip joint with the head of the femur, which will be described shortly. The sacrum articulates with the left and right hip bones to complete the pelvic girdle posteriorly. You may recall from the solid anatomy lecture on the deep back that the sacrum is formed by the 5 sacral vertebrae that fuse to form a single triangular bone. The body of the first sacral vertebra protrudes anteriorly as the sacral promontory. Extending laterally from the body of the first sacral vertebra are the bilateral ala. That term sounds familiar. It's because moments ago we learned that the ilium also has an ala, or wing. The auricular surfaces, which articulate with the matching auricular surfaces of the ilia, are found on the superior part of the lateral sides of the sacrum. The vertebral canal of the spinal column is continuous with the sacral canal in the sacrum, which ends inferiorly in the sacral hiatus. The sacral canal contains the distal portion of the cauda equina, which, as you may recall from the solid anatomy lecture on the deep back and spinal cord, is the collection of dorsal and ventral roots arising from the lumbar, sacral, and coccygeal levels of the spinal cord. The sacral and coccygeal, dorsal, and ventral roots combine to form spinal nerves within the sacral canal. The first 4 sacral spinal nerves divide into dorsal and ventral rami within the canal. The ventral rami exit through the 4 ventral, or anterior, sacral foramina to enter the pelvis, while the dorsal rami exit through the 4 dorsal, or posterior sacral foramina to reach the deep back. The 5th sacral spinal nerve and the coccygeal spinal nerve exit the sacral hiatus before dividing into dorsal and ventral rami. Before we discuss the hip joint, let's review the joints of the pelvis. The weight of the body is transmitted down the vertebral column and then to the sacrum through the lumbosacral joints, which are the intervertebral joint and the zygapophyseal joints between L5 and S1. The intervertebral joint between the bodies of L5 and S1 is similar to the intervertebral joints of the rest of the vertebral column. It is a secondary fibrocartilaginous joint with an intervertebral disc between the vertebral bodies. The anterior and posterior longitudinal ligaments reinforce the joint, as do the iliolumbar ligaments that run between the iliac crest and the transverse processes of L5. The iliolumbar ligaments resist rotation of L5 with respect to the sacrum. The lumbosacral zygapophyseal joints, or facet joints, are synovial joints between the superior articular processes of S1 and the inferior articular processes of L5. The zygapophyseal joints and the intervertebral joints resist compressive forces on the vertebral column. The weight of the body is transmitted from the sacrum to the hip bones through the sacroiliac joints. The auricular surfaces of the ilia and the sacrum articulate to form these joints. The sacroiliac joints are synovial joints, but have extremely limited mobility as they are designed primarily for bearing weight. The sacrum is shaped like a wedge being pushed between the hip bones, so very strong ligaments are required to hold the sacroiliac joints together. The anterior and posterior sacroiliac ligaments, consequently, are extremely thick. In anatomical position, the sacrum is tilted anteriorly, so the weight of the body tends to exert an anterior rotational force on the sacrum with respect to the hip bones. 2 ligaments that help to resist this rotational force are the sacrotuberous ligament, which runs from the sacrum to the ischial tuberosity, and the deeper sacrospinous ligament, which runs from the sacrum to the ischial spine. You may recall from the solid anatomy lecture on the pelvic wall that these ligaments, with the greater and lesser sciatic notches on the hip bones, form the greater and lesser sciatic foramina. The pubic symphysis is the secondary fibrocartilaginous joint between the symphysial surfaces of the bodies of the left and right pubis. There is a fibrocartilaginous disc between the symphysial surfaces that assists in shock absorption when compressive force is applied to the pelvis. The pubic symphysis resists compressive force as well as tensile force, or force that tends to separate the hip bones, as when a gymnast performs a split, for instance. The joint is reinforced by superior and inferior pubic ligaments that run between the bodies of the left and right pubis. The sacrococcygeal joint, between the bodies of the fifth sacral vertebra and the first coccygeal vertebra, is another secondary fibrocartilaginous joint. It has a small intervertebral disc and allows flexion and extension unless it becomes ossified and fused, as often occurs later in life. Since we're going to discuss the hip joint in a moment, let's first describe the femur, which articulates with the hip bones to form the hip joint. The femur is the only bone in the thigh, which is the portion of the lower extremity between the hip joint and the knee joint. The femur is the longest and heaviest bone of the body. Its length makes it an effective lever for locomotion, and its mass enables it to bear the weight of the body. At its proximal end is its rounded head, which is covered with articular cartilage, since, as we mentioned moments ago, it forms the hip joint with the acetabulum of the hip bone. The longest portion of the bone is the shaft, or body, which is united with the head by the neck of the femur. The proximal end of the shaft bears a pair of very prominent protuberances, the greater trochanter, which projects laterally, and the lesser trochanter, which projects posteriorly. The trochanters are united by a prominent intertrochanteric crest on the posterior side of the femur, and by a more subtle intertrochanteric line on the anterior side of the femur. The shaft of the femur ends distally in the rounded medial and lateral condyles, which are covered with articular cartilage. The femoral condyles form the tibiofemoral, or knee joint, with the proximal end of the weight-bearing bone of the leg, the tibia. Medial and lateral epicondyles are protrusions that extend laterally and superiorly from the condyles. Extending superiorly from the medial epicondyle is the pointed adductor tubercle, which serves as an attachment point for part of the adductor magnus muscle, which will be described in the solid anatomy lecture on the thigh. The thick, rough line running vertically along the posterior side of the shaft of the femur is the linea aspera, which, conveniently, is Latin for rough line. The linea aspera ends superiorly by bifurcating into the gluteal tuberosity posteriorly and the pectineal line anteriorly. The weight of the body passes from the hip bones to the lower extremities through the hip joints. The hip joint is a synovial, ball and socket joint. The ball, of course, is the head of the femur, while the acetabulum is the socket. The deeper the socket of a ball and socket joint, the more stable the joint. If you've watched the solid anatomy lecture on the bones, joints, and actions of the upper extremity, you may recall that the socket of the glenohumeral joint, the glenoid fossa, was effectively made deeper by a lip of cartilage attached to its periphery, the glenoid labrum. Likewise, the socket of the hip joint is deepened by the acetabular labrum, a lip of cartilage attached to the circumference of the acetabulum that extends just beyond the rim of the bone. The hip joint is held together by 4 very strong ligaments. 3 of them contribute to the capsule of the hip joint. The iliofemoral ligament is a V-shaped ligament whose apex attaches lateral and posterior to the anterior iliac spine. Its arms, if you will, attach to 2 separate points on the intertrochanteric line of the femur. The pubofemoral ligament spans the superior pubic ramus and the intertrochanteric line, attaching just deep to the inferior arm of the iliofemoral ligament. The ischiofemoral ligament runs between the body of the ischium to the neck of the femur and the medial surface of the greater trochanter. The fourth ligament of the hip joint, which does not contribute to the capsule because it is found inside the capsule, is the ligament of the head of the femur. It runs from a notch on the inferior part of the acetabulum to an indentation in the head of the femur, which is called the fovea. While this ligament is intracapsular, it is not within the synovial lining. Instead, it is surrounded by the lining and is extrasynovial. The hip joint is multi-axial. There are 6 actions about the hip joint to consider. Flexion of the hip causes a decrease in the angle between the anterior surface of the thigh and the trunk of the body. Extension increases this angle. Abduction of the femur at the hip joint, often stated more simply as abduction of the hip joint, involves moving the femur away from the midline of the body. Adduction of the femur at the hip joint brings the femur toward the midline of the body. The femur may also be rotated at the hip joint. Lateral rotation of the femur at the hip joint involves rotating the femur away from the midline, while medial rotation of the femur at the hip joint involves rotating the femur toward the midline of the body. Clinically, these actions are often referred to as external rotation instead of lateral rotation, and internal rotation instead of medial rotation.
It's time for that clinical correlation. So let's spend a little bit of time talking about hip fractures. Now, when you hear about someone breaking their hip, they've usually not broken their hip bone, but rather the neck of the femur. Now, if the arteries traveling along the neck of the femur to the femoral head are ruptured when the bone breaks, then that blood supply to the proximal femur is cut off, and that portion of the bone dies. In a clinical situation, this is known as a avascular necrosis. Now, the remedy for that is replacement of the dead bone with a prosthesis, which is performed in a procedure commonly referred to as a hip replacement. Now, most patients with a hip fracture report a fall followed by an inability to bear weight on the extremity, and then of course pain in the groin area as well. Now, a few can walk with assistance, say with crutches or a cane or a walker, but still they have groin or buttock pain on weight bearing, and that seems to get worse with ambulation. Now, occasionally patients report pain referred to the supracondylar region of the knee actually, and elderly patients with hip pain after a fall should be treated as if they even have a hip fracture until you can prove otherwise. Patients with displaced hip fractures will lie with the limb externally rotated, abducted, so abducted, and then shortened. And then any attempts to gently rotate that limb while the hip is extended is extremely painful. Patients are unable to do what's called the straight leg raise. So if they're going to lift the heel on the affected side off of the bed or the ground, if they're still on the ground, while keeping that knee straight, very, very painful. They really can't do it. All right, so now let's go over a few of those questions now. First one here we have, what medical complications frequently accompany hip fractures? We haven't gone over this, but thromboembolic events, things like DVTs, deep vein thrombosis, pneumonia, decubitus ulcers, and urinary tract infections. Now, why does that happen? Well, really, when you have a hip fracture, you can't move very much, so you're stuck in bed, so you can get those type of things. Next, what are the risk factors for hip fracture? So, advanced age, sedentary lifestyle, smoking, alcoholism, use of psychotropic medication, and then also dementia. Okay, now let's get back to that lecture and talk about the muscles of the gluteal region.
All of the muscles of the gluteal region act on the hip joint. Typically, the largest muscle of the body by weight is the gluteus maximus, which overlies the other, smaller, gluteal muscles. The gluteus maximus originates on the posterior part of the lateral side of the wing of the ala, the dorsum of the sacrum and coccyx, and the sacrotuberous ligament. It inserts on the gluteal tuberosity of the femur and on the iliotibial tract. The iliotibial tract, often referred to clinically as the IT band, is a thickened section of the deep fascia of the thigh, the fascia lata, that runs from the iliac crest to the lateral condyle of the tibia. The gluteus maximus extends the hip joint and rotates the femur laterally at the hip. The gluteus medius, which is deep to the gluteus maximus, originates from the lateral side of the ala of the ilium just inferior to the iliac crest and inserts on the superolateral part of the greater trochanter of the femur. Deep to the gluteus medius, the gluteus minimus originates from the middle portion of the lateral side of the ala of the ilia and inserts on the anterolateral part of the greater trochanter. The gluteus medius and minimus abduct and medially rotate the femur at the hip joint. The gluteus medius and gluteus minimus also perform an important function during locomotion. They keep the pelvis level. When one foot is raised off the ground, the pelvis tends to tilt inferiorly toward that side. However, the contralateral gluteus medius and gluteus minimus muscles contract when the foot is raised, which keeps the pelvis level and prevents the foot from being dragged during locomotion. The tensor fascia lata originates on the iliac crest and inserts on the iliotibial tract. It performs 3 actions at the hip joint: flexion, abduction, and medial rotation of the femur at the hip joint. To the anatomist who named the piriformis, it evidently resembled a pear, since the Latin translation of its name is pear-shaped. It originates inside the pelvis on the anterior surface of the sacrum, just lateral to the anterior sacral foramina, and narrows as it passes through the greater sciatic foramen deep to the sacral plexus of nerves, which will be described later in this lecture. The piriformis enters the gluteal region deep to the gluteus maximus and inferior to the gluteus medius. It inserts on the medial side of the superior part of the greater trochanter of the femur and is a lateral rotator of the femur at the hip joint. The obturator internus and externus muscles originate from the parts of the pubis and the ischium that contribute to the periphery of the obturator foramen. The internus covers the medial side of the foramen, while the externus covers the lateral side. Between the two muscles is the obturator membrane, which fills the foramen, except for the portion through which the obturator canal passes. The insertion tendon of the obturator internus passes through the lesser sciatic foramen to reach the gluteal region, then attaches to the superior part of the medial surface of the greater trochanter. The insertion tendon of the obturator externus passes posterior to the neck of the femur and also inserts on the medial side of the superior part of the greater trochanter. The obturator internus and externus muscles are lateral rotators of the femur at the hip joint. Superior and inferior to the tendon of the obturator internus is a pair of muscles that look so much alike that they were given the Latin name for twins, gemelli. The superior gemellus originates from the ischial spine, while the inferior gemellus originates from the ischial tuberosity. The insertion tendons of the gemelli muscles usually blend in with that of the obturator internus, so they are another pair of lateral rotators of the femur at the hip joint. The quadratus femoris is a 4-sided muscle originating from the ischial tuberosity inferior to the inferior gemellus and inserting on the intertrochanteric crest. It is yet another lateral rotator of the femur at the hip joint. The nerves of the gluteal region, those providing innervation to the gluteal muscles, are branches of the sacral plexus. The sacral plexus is composed of the lumbosacral trunk, which combines part of the ventral ramus of L4 with all of the ventral ramus of L5, and the ventral rami of S1, S2, S3, and S4. Most of the branches of the sacral plexus leave the pelvis through the greater sciatic foramen to reach the gluteal region. 2 exceptions are the nerve to the piriformis, which of course innervates the piriformis, and branches to the levator ani muscles. The nerve to the piriformis is made up of fibers from the ventral rami of the S1 and S2 spinal nerves, while the branches to the levator ani usually come from S3 and S4. The pudendal nerve carries contributions from S2, S3, and S4. It enters the gluteal region through the greater sciatic foramen, but does not innervate anything in there. Instead, it leaves the gluteal region through the lesser sciatic foramen and enters the perineum. The nerve to the obturator internus, on the other hand, follows the same course as the pudendal nerve, but ends by innervating the obturator internus muscle upon passing through the lesser sciatic foramen. Before it enters the lesser sciatic foramen, it gives off a branch to the superior gemellus. The nerve to the obturator internus is derived from L5, S1, and S2. The superior and inferior gluteal nerves are named according to their relation to the piriformis muscle when they enter the gluteal region. The superior gluteal nerve passes through the greater sciatic foramen superior to the piriformis, while the inferior gluteal nerve passes through the greater sciatic foramen inferior to the piriformis. The superior gluteal nerve carries branches from L4 to S1. It passes between the gluteus medius and minimus to innervate both muscles, then sends a branch laterally to the tensor fascia lata. The inferior gluteal nerve carries branches from L5 to S2. It innervates the gluteus maximus. When the nerve to the quadratus femoris passes through the greater sciatic foramen at the inferior margin of the piriformis, it continues inferiorly deep to the superior gemellus, the obturator internus, and the inferior gemellus, and plugs into the underside of its target muscle, the quadratus femoris. It also gives off a branch to the inferior gemellus. The nerve to the quadratus femoris carries contributions from L4 through S1. If you're asking yourself at this point, what are the names of the nerve to the piriformis, the nerve to the obturator internus, and the nerve to the quadratus femoris? Well, you've answered your own question. They don't have fancy names like most of the nerves in the body. They are just officially called the nerve to the piriformis, the nerve to the obturator internus, and the nerve to the quadratus femoris. The largest nerve of the body, the sciatic nerve, carries contributions from the ventral rami of spinal nerves L4 to S3. It emerges in the gluteal region at the inferior margin of the piriformis, but does not give off any branches until it reaches the posterior compartment of the thigh. Running in parallel with the sciatic nerve is the posterior cutaneous nerve of the thigh, or posterior femoral cutaneous nerve, which carries contributions from S1 to S3. It runs inferiorly to the posterior compartment of the thigh, where it innervates skin. But it also gives off branches that reflect up to the skin over the gluteal region that will be described at the end of this lecture. The obturator externus is not innervated by a branch of the sacral plexus. It is innervated by the obturator nerve, a branch of the lumbar plexus that passes through the obturator canal on its way to the medial compartment of the thigh, where it innervates several muscles and an area of skin. Remember that the obturator internus is innervated by the nerve to the obturator internus, a branch of the sacral plexus, while the obturator externus is innervated by the obturator nerve, a branch of the lumbar plexus. Blood supply to the gluteal region is mainly provided by the superior and inferior gluteal arteries, which are branches of the internal iliac artery that originate within the pelvis. The gluteal arteries usually pass between ventral rami contributing to the sacral plexus. The superior gluteal artery then crosses the superior margin of the piriformis muscle, while the inferior gluteal artery crosses the inferior margin of the piriformis. Both gluteal arteries then pass through the greater sciatic foramen and emerge in the gluteal region on opposite sides of the piriformis. The superior gluteal artery travels laterally from the superior margin of the piriformis, gives off one or more branches to the gluteus maximus, and dives between the gluteus medius and minimus, supplying both muscles. The inferior gluteal artery passes inferolaterally from the inferior margin of the piriformis, gives branches to the gluteus maximus, and then forms anastomoses with the superior gluteal artery and arteries of the thigh, including the femoral circumflex arteries. Venous return from the gluteal region is accomplished largely by the superior and inferior gluteal veins, which travel with the arteries and pass through the greater sciatic foramen to enter the pelvis, where they drain into the internal iliac vein. There are usually multiple superior and inferior gluteal veins surrounding the corresponding arteries, forming venae comitantes, like those described in the solid anatomy lectures on the upper extremity. To consider cutaneous innervation to the gluteal region, divide the skin into superomedial, superolateral, and inferior zones. The superomedial zone, which covers most of the skin of the gluteal region, receives innervation from branches of the dorsal rami of lumbar and sacral spinal nerves. These branches are often called the superior and middle cluneal nerves. Clunes, by the way, is the Latin word for buttocks. Recall from the introductory solid anatomy lectures that skin on the dorsum of the trunk is innervated in a dermatomal pattern by dorsal rami, while skin on the ventral side of the trunk and on the extremities is innervated by ventral rami. The only portion of the lower extremity that receives cutaneous innervation, or any kind of innervation for that matter, from the dorsal rami is this superomedial zone of the gluteal region. All of the remainder of the skin over the lower extremity and all of the muscles acting on the lower extremity are innervated by ventral rami of spinal nerves. The superolateral zone of skin on the gluteal region is innervated by branches of the lateral cutaneous nerve of the thigh, which is a branch of the lumbar plexus of nerves. The skin over the inferior zone of the gluteal region is innervated by branches of the posterior cutaneous nerve of the thigh, or posterior femoral cutaneous nerve, which, as we mentioned earlier in this lecture, is a branch of the sacral plexus. These branches are also called the inferior cluneal nerves. However, most of the branches of the posterior cutaneous nerve of the thigh are involved in innervation of skin on the posterior side of the thigh, as you'll learn in the next lecture in this series, the solid anatomy lecture on the thigh.
So that covers the gluteal region of the lower extremity. Now I want you to pause the video and answer the end of session quiz questions, and then we'll go through those answers together. Let's get going. First question. What is the bony structure on which you sit? So that's your ischial tuberosity. Next question. What four ligaments hold the hip joint together? So you have the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, and the ligament of the head of the femur. Next question. What muscle does the inferior gluteal nerve innervate? That's going to be your gluteus maximus. Next. Which muscles does the superior gluteal nerve innervate? So we have the tensor fascia lata, the gluteus medius, and the gluteus minimus. Next, name the main extensor muscle of the thigh that, when damaged, disables a person from getting out of a chair. Again, that's going to be your gluteus maximus. Next question, which muscles are responsible for medial rotation of the femur at the hip joint? So we have the tensor fascia lata muscle, the gluteus minimus, and the gluteus medius. Okay guys, we're almost done. Now we've provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your examination. So label the images and then we'll be finished. Thanks.